Hello everyone, today we're going to start where emergency care truly begins. And this is outside the hospital. Pre-hospital care is not a prelude or an afterthought. It is a critical phase of emergency medicine that directly affects morbidity and mortality. As future PAs, you will often receive patients who have already had airway interventions, medications, spinal mobilization, hemorrhage control, or cardiac resuscitation. This will all be performed before you even see the patient. So understanding what EMS can do, why they did it, and what constraints they were working under is very essential to providing safe, informed, and respectful care in the emergency department. Emergency medical services, as we say EMS, they represent the extension of emergency medical care into the community. This means care is initiated at the point of injury or illness, not at the hospital door. EMS providers operate in unpredictable environments, roadside ditches, private homes, industrial settings, disaster scenes, fire, smoke, rain, lightning, traffic. So they must make rapid decisions with limited information, minimal diagnostics under unsafe conditions the majority of the time. So from a systems perspective, EMS is the first clinical link in the chain of survival. What happens in these first few minutes, airway positioning, hemorrhage control, early defibrillation, often determines whether downstream hospital care can even be effective. Here are your objectives. We'll be discussing these, and this is the basis of the presentation today. Here's some objectives on pre-hospital equipment I want you to look over. And here are some objectives on helicopter transport. We'll go over this in depth shortly. As well as EMTALA. This is a very litigious subject here that you need to understand and know well. And also transport of neonatal and pediatric patients as well. You need to understand this as well. So the origins of EMS. So modern EMS systems exist because legislative recognition that injury and sudden illness are public health issues. That is how it all began. It began with the National Highway Safety Act of 1966, which formally established EMS as a coordinated system under the Department of Transportation. So this context and history explains why EMS emphasizes response time, scene safety, and transport efficiency. EMS evolved from trauma response and motor vehicle injury prevention, not from hospital-based medicine. So this emergency medical services, extended emergency medical care into the community. This means providing immediate care and transfer to those in need, ensuring that critical medical services are available outside of hospital settings. So this is how the modern EMS system started, and this helps us ensure care from the actual community into the hospital setting. It's very important. Okay, next we're going to go over some state EMS laws and regulations. So although federal law shapes EMS broadly, states regulate EMS practice. This includes defining levels of ambulance capability, training requirements, required equipment, and medical oversight. This means EMS practice varies geographically. A paramedic in one state may be able to perform procedures that are not permitted in another. As PAs, you must understand your local EMS scope of practice to interpret pre-hospital care accurately. For instance, regarding ambulance surface capability, the states define various levels of ambulance service capability, such as basic life support, BLS, and advanced life support, ALS. There are also specific training requirements for EMS providers. So states specify training requirements for different levels of EMS providers, ensuring they meet national standards. In addition, equipment requirements, ambulances. The states will always outline the necessary equipment that ambulances must carry to provide adequate patient care. Physician leadership and accountability. So the state also sets requirements for physician leadership in EMS systems. This ensures accountability and oversight of the actual EMS teams. Training and certification. EMS providers are categorized into different levels, such as EMT, AEMT, and Paramedic. Each level here has a specific training requirement, with paramedics receiving the most advanced training. So if I were to ask you who receives the most advanced training, you're going to say paramedics. Initial communication. So effective communication is crucial between dispatch, EMS providers, and receiving facilities. This helps to ensure timely and accurate information exchange, which is so very vital for patient care. Communication is highly important. And the most important thing here is the patient handoff. Protocols for transferring patient care from EMS hospital staff emphasize the importance of accurate and thorough communication. So to ensure the continuity of care and patient safety, you have to have a high yield handoff. As soon as a paramedic walks into the trauma bay or the emergency room, you need to communicate with that paramedic, ask everything you need to ask, what was done, what's going on, so that way you're informed on how you can proceed the handoff of care of this patient, okay? And don't forget this when it comes time for FRTG simulation at their facility, okay? All right, this slide here highlights the two most influential federal statutes in EMS development. The National Highway Safety Act, which established leadership and oversight, while the Emergency Medical Services System Act of 1973 provided funding and standardization. Okay, these laws transformed EMS from fragmented local services into coordinated regional systems with standardized training, equipment, and communication. The result of this was improved access, consistency, and patient outcomes nationwide. So here we're going to start with state-specific EMS regulations. So at this point, we transition from federal structure to state-level control, which is where EMS actually functions day to day. Every state has EMS office that regulates licensure, certification, quality assurance, and disciplinary actions. Importantly, states define scope of practice, while National EMS Scope of Practice Model provides a framework, which states ultimately decide what EMTs, AEMTs, and paramedics are actually allowed to do. This has direct implications for you clinically. What EMS can initiate in one state may be prohibited in another. As a PA, understanding your local EMS regulations is essential for interpreting pre-hospital care and for serving as a future medical director or quality reviewer. In addition to this, there are some components to the EMS system. So this slide here emphasizes how EMS systems are operationally structured. Ambulance services are categorized by capability, not just by staffing. Basic life support units are designed to manage airway, positioning, oxygenation, CPR, AED use, and basic trauma care. Advanced life support units add cardiac monitoring, IV therapy, medications, and advanced airway management. From a systems perspective, this stratification allows efficient deployment of resources. Clinically, it tells you what interventions are realistically possible before hospital arrival. So you understand the difference between ALS and BLS ambulances, okay? So you're going to go over some equipment here. So AEDs, that's basic life support equipment for cardiac arrest, oxygen delivery systems, nasal cannulas and masks are with the BLS. Basic airway tools like oropharyngeal, nasopharyngeal airways. The ALS equipment has advanced airway tools such as endotracheal tubes, laryngoscopes, cardiac monitors for heart rhythms, vital signs. They also have IV therapy equipment, catheters, fluids, medications. So you can see the difference between the equipment and the capabilities and responsibilities between ALS ambulance and BLS ambulance. So ALS also has specialized equipment for trauma care, such as spinal mobilization, backboard, cervical collars, hemorrhage control, which includes tourniquets, dressings, bandages, and so on and so forth. So know the differences between the two. addition to this, there's got to have somebody in charge, right? So EMS is not autonomous. It is a physician-directed system. States require EMS agencies to have medical directors who oversee protocols, training, and quality assurance. So they're not just running rogue throughout the states and in the cities. So medical directors are responsible for protocol development, continuing education, and review of high-risk or adverse events. This will create accountability and ensures that evidence-based practice is being conducted. As PAs, you may one day function in EMS leadership roles, and this slide underscores the ethical and legal responsibility tied to this medical oversight. So he has some titles here, medical direction. So the state requires EMS systems to have physician medical directors who provide oversight and establish all the protocols here. Okay, so this is important to know that there is somebody in charge and who will they report to. All right, so EMS funding. This is one of the most fragile components of the healthcare system. So these services, it's kind of like a Frankenstein patchwork of federal grants, state funding, local taxes, and reimbursement from insurers. As you can see, this is why they probably triplicate each charge. So reimbursement often only occurs if a patient is transported, not treated on scene. So the money is in the transport, not on the actual care taken at the scene. So that's where they get their funding from actual transporting patients to the hospital, not treating them on the scene. So you understand that. So this creates perverse incentives and contributes to overtransport and ED overcrowding. You can see the dilemma we have here. Okay. So understanding EMS funding challenges helps contextualize staffing shortages, response times, and rural access issues. So just kind of keep that in mind. All right, so specialized EMS services and programs, we're going to discuss this now. So there's also expanded EMS roles. So community paramedicine allows paramedics to provide preventive care, chronic disease monitoring, and post-discharge follow-up. This will help to reduce hospital readmissions. So air medical services extend EMS capabilities across distance and terrain, but their use must be clinically justified. We'll go over that in a second. So these programs direct the evolution of EMS from a reactive system to a more integrated healthcare delivery model. Okay, in addition to this, emergency care does not begin with EMS, it begins with bystanders. So public education initiatives teach communities how to access EMS and provide immediate care before responders arrive. So widespread CPR training has been shown to significantly increase survival from out-of-hospital cardiac arrest. From a public health perspective, this is the most effective interventions available. So here, there's other forms of first aid. So there's also campaigns like Stop the Bleed campaign, which highlights how early hemorrhage control saves lives. These are people in the community learning how to do this before the EMS gets there. This is all an effort to save lives. So as you understand, severe bleeding kills faster than airway compromise in many trauma cases. There's also wilderness first aid programs, which prepare individuals to manage injuries when EMS access is delayed if they're out hiking somewhere in the mountains or in the wilderness. So these programs are especially relevant in rural, recreational, and disaster settings. So here we have the scope of practice model, which defines what EMS providers are authorized to do at each level of certification. It establishes 4 levels here. You have EMR, EMT, AE, EMT, and Paramedic. The goal is standardization while allowing states flexibility. From an educational standpoint, this framework ensures consistent expectations across training programs nationwide. So this helps define the duties and services that each EMS personnel are authorized to perform at different levels of certification. So here they are with the emergency medical responder level. This helps provide immediate life-saving care to critical patients. on the scene. This is done prior to the arrival of EMS. This could be your local community citizen, a police officer, EMR. So emergency medical technician, EMT, offers basic emergency medical care and transportation for critical emergency patients. An advanced EMT, AEMT, provides both basic and limited advanced emergency medical care and transportation, and a paramedic delivers advanced emergency medical care and transportation for critical and emergent patients. So emergency medical responders are often the first on the scene. Think of police officers, firefighters, or community responders. Their role is immediate life-saving intervention, CPR, hemorrhage control, airway positioning. They stabilize patients during a critical early emergency before higher level EMS arrives. An example of an emergency medical responder in action could be a police officer who arrives first at the scene of a car accident. The officer, trained as an emergency medical responder, provides immediate life-saving care by assessing the patient's condition, performing CPR if necessary, and controlling any bleeding. The EMR stabilizes the patient until more advanced EMS personnel such as EMTs or paramedics arrive to take over and transfer the patient to the hospital. This role here is crucial in ensuring that patients receive timely and effective care in critical moments before additional help arrives. Next up is the emergency medical technician, the EMT. EMTs provide the foundation of EMS care. They perform patient assessment, administer oxygen, assist with medications, manage basic airways, and transport patients. Most EMS calls are handled by EMTs, making them central to emergency care delivery. An example of emergency medical technician in action could be responding to a 911 call for a person experiencing chest pain. The EMT arrives on the scene, quickly assesses the patient condition, and provides initial care such as administering oxygen and performing an electrocardiogram to monitor the heart. The EMT then transfers the patient to the nearest hospital, continuing to monitor vital signs and provide necessary care en route. This role is crucial in providing timely and effective emergency medical care, ensuring that the patient receives the best possible treatment before reaching the hospital. And next we have the Advanced Emergency Medical Technician. So AEMTs expand upon EMT skills by adding IV access, more medication administration, and advanced airway techniques. They serve as an important bridge between BLS and ALS, particularly in rural or resource-limited settings. Paramedics. So paramedics represent the highest level of pre-hospital care. They perform advanced airway management, administer a broad range of medications, interpret complex ECGs, and manage critical patients. Excuse me. In many ways, paramedics function as mobile critical care clinicians, making high-stakes decisions in every type of environment. So an example of paramedic in action could be responding to a severe car accident. Upon arrival, a paramedic quickly assesses the situation and identifies a patient with multiple injuries, including suspected spinal injury and severe bleeding. The paramedic stabilizes the patient. He or she uses advanced airway management tools to secure the patient's airway and ensures that they are breathing properly. They also control bleeding by applying a tourniquet and hemostatic dressings to control severe bleeding. They're able to monitor vital signs by using cardiac monitors to track the patient's heart activity and start IV line to administer fluids and medications. And they also coordinate with the hospital by communicating with the receiving hospital to provide a detailed report on the patient's condition and treatments administered. In addition to that, they also transport the patient, which ensures the patient is safely transported to the hospital to continue to provide advanced care en route. So this example highlights the paramedic's ability to perform advanced medical procedures and make critical decisions in high pressure situations, ensuring the patient receives the best possible care before reaching the hospital. So here we discuss how training length correlates with scope. There's EMTB programs are short and focused on basic care. Paramedic programs are typically 2 years and include advanced physiology, pharmacology, and clinical rotations. So you need to understand the training depth that helps contextualize clinical decision making in the field. The EMTBs are very limited in their skills and can only perform basic life support functions. EMTI are permitted to do everything an EMTB is. However, they are granted the ability to start IVs and administer some basic medications for asthma, cardiac arrest, and diabetic patients. Okay, so communication is the backbone of EMS, as we've discussed. There's something called emergency medical dispatch. So they prioritize all the calls and provide pre-arrival instructions. So once transport begins, EMS must communicate with the receiving facility to prepare the emergency department for arrival. Paramedics operate under indirect medical control through protocols, but once communication is established, emergency physicians may provide direct medical control. So the emergency medical dispatch personnel, they're trained to prioritize dispatch for pre-arrival instruction. Air transport. So now we transition from ground transport to air medical transport, which is an extension of EMS rather than a replacement. Helicopter transport is typically determined by EMS in the field and is used when ground transport will result in unacceptable delays in definitive care. This decision hinges on time, distance, patient acuity, and terrain. Importantly, air transport is not automatically superior. It introduces risks such as weather exposure, limited access to patient during flight, and increased physiologic stress. Clinically, you must always ask, does this patient benefit from speed enough to justify the risk? All right, so we're going to discuss one of the most important pre-hospital principles: transport to the closest appropriate facility. EMS is not tasked with finding the best hospital in abstract terms. They must balance immediacy, capability, and patient stability. Hospitals may be bypassed only if another facility offers resources that significantly improve patient outcomes, such as trauma, surgery, or interventional cardiology. Over triage and unnecessary bypass strain healthcare systems and delay care. So, for example, if here in town in Orlando, if something were to happen at the Kia Center here during a basketball game, the Orlando Magic, and someone says, take them down to Winter Park Hospital, but literally 2 blocks away is Orlando Regional Medical Center. So if they do travel to Winter Park Hospital, it's going to delay care, it's going to extend resources. So, bypassing the level 1 trauma center for a tertiary level 3 hospital, community hospital, is not what they are supposed to do. So they're always trained to go to the nearest hospital to provide care for the patient. I want you to remember that as we discuss the rest of this lecture. So each level here plays a crucial role in the trauma care system. This ensures that patients receive the appropriate level of care based on their based on their needs and the resources available. So we talk about trauma centers. So as I mentioned, they're organized in a tiered system so that patients receive care that matches injury severity. Trauma centers are classified into 5 levels. So 5 levels for trauma centers. Each of these trauma centers has a specific capability and expectations. So this system allows EMS to triage patients appropriately to ensure that high acuity trauma patients reach centers with surgical critical care and subspecialty resources available 24/7. So here we're going to discuss the levels of trauma. So trauma center levels 1 through 5. So here's an overview of the trauma center hierarchy. I want you to know this. The key concept here is capability escalation. Level 1 trauma centers provide comprehensive care, including research and education. Level 2 centers provide definitive care, but may transfer highly complex cases. Level 3 through 5 focus on stabilization and transfer. From a PA standpoint, understanding trauma levels helps you anticipate what resources are available when a patient arrives and what transfers may be required. Okay, so get familiar with these levels. Okay, now we're going to go deep dive into a level 1 trauma center. So level 1 trauma centers are comprehensive regional resources. Regional resources. They provide total care from injury prevention through rehabilitation. These centers have in-house surgical coverage at all times and serve as referral centers for complex trauma cases. They are also responsible for education, research, and quality improvement, which drives trauma care forward naturally. Here are some of the capabilities. In addition to clinical care, level 1 trauma centers are leaders in trauma system development. They conduct ongoing quality assessment, participate in research, and maintain minimum patient volume requirements to ensure clinical proficiency. These centers often serve as training hubs for residents, fellows, and advanced practice providers, such as yourselves. These are what they call the teaching hospitals are found in the level 1 trauma centers. It's basically what I'm just trying to say here. So level 2 trauma centers. So these are capable of initiating definitive care for most injuries. They have immediate access to general surgeons and critical specialists, but may refer certain complex cases to the level 1 trauma center. For example, major vascular or neurosurgical trauma. Clinically, many trauma patients receive excellent care at level 2 facilities without ever needing to be transferred to a level 1 facility. Next is a level 3 trauma center. So level 3 trauma centers focus on rapid assessment, resuscitation, and stabilization. They can manage many emergency surgeries but rely on formal transfer agreements for patients requiring higher level care. These centers are critical for rural, I can never say that, rural and community access to trauma services throughout in the country somewhere. That's what they help with. Okay, so what is the transfer role for a level 3 trauma center? So here we're going to highlight the importance of transfer agreements. So level 3 centers act as stabilizing hubs. All they do is stabilize the patient. So they ensure the patient are quickly assessed and then moved to facilities with greater resources when necessary. From a system standpoint, this prevents overwhelming level 1 centers while ensuring timely care. Next on the list is a level 4 trauma center. So level 4 trauma center provide advanced trauma life support prior to transfer. They may lack surgical capabilities but are trained to rapidly identify life-threatening injuries and initiate stabilization. These centers are often located in rural areas and play a critical role in early trauma management. So basically, they will stabilize the patient and then transfer as necessary. So level 5 trauma center. So these centers provide initial evaluation and stabilization with prompt transfer to higher level facilities. While resources are limited with these facilities, their role is essential in ensuring early recognition and safe transfer of injured patients. So get familiar with all the levels of trauma centers for your exam and for your real world experiences. Here are some of the specialties that are available at level 1 trauma centers. So we're going to list the breadth of specialty services. As you can see here, they have a multitude of services here, such as orthopedics, neurosurgery, critical care, anesthesia, and radiology. These ones I just mentioned, they must be available at all times, so they don't get to take a break. So this multidisciplinary availability is what allows level 1 centers to manage the most complex trauma cases, and these are the most busiest ones as an employee, as a PA, and you'll be always busy there. So, in regards to healthcare implications. So, as I was talking about earlier, bypassing closer facilities can delay care, especially if the patient requires immediate stabilization. So EMS, they must weigh the risks of delay against the benefits of specialized resources. This is a recurring theme in emergency medicine. The fastest care is not always the best care. Okay, so if you know that a specific hospital does great things, but there's literally one a block away from where the scene happened, you need to get them to the closest facility to stabilize them first, and then they will handle the transfer over to the much higher facility for further care. Okay, please keep that in mind always. In addition to this, there's always going to be healthcare implications with cost and efficiency. So there is an economic impact of transport decisions. Longer transports increase operational costs, and specialized centers often incur higher treatment costs and expenses, as you can imagine. So frequent diversions also strain EMS availability, potentially delaying response to other emergencies. Efficient system utilization benefits both patients and communities. So bypassing longer trips, more gas, especially nowadays, limited resources if they're needed on the other side of town next, but they're traveling elsewhere. So just understand that there are costs with delaying treatment by going to another facility. That is why closest facility possible is the first choice for the injured patient. So where do you go? So here's a critical thinking scenario I have for you guys. This will challenge some of your assumptions. Even in pediatric trauma, patients in cardiac or respiratory arrest must be stabilized at the nearest facility. I will repeat that. Even in pediatric trauma, patients in cardiac or respiratory arrest must be stabilized at the nearest facility. This reinforces the principle that immediate life-saving interventions take precedence over ideal destination selection. EMS decisions are grounded in physiology, not institutional preference. So yeah, they will probably have to send a pediatric patient to a non-pediatric hospital in order just to stabilize them if they're having a cardiac or respiratory event. Then, once they're stabilized, we can transfer them to the pediatric trauma center. Okay. All right. So up to this point, we talked about EMS from a systems and logistics perspective. Now we need to confront the reality that many EMS decisions exist in legal gray zones. So here's the challenge. EMS often has to make destination decisions without seeing labs, imaging, or consultants. They must rely on protocols, experience, and medical control. And those decisions can later be scrutinized in court. As PAs, especially in emergency medicine, you will sometimes question EMS decisions in retrospect. Okay, this slide reminds us to respect the uncertainty and time pressure under which those decisions are made. So don't be judging, what happened prior to you by the patient getting there. Understand that the EMS personnel were probably dealing in the most uh, stressful situations, car fire, shootout, whatever. I mean, building collapsed. So they have to make decisions on the run just to save the person's life. So this is just what that's saying. Okay. All right. So there's a tertiary care and interfacility transfers. So once the patient stabilized, it can be transferred to a higher facility. So most patients are not taken directly to tertiary centers. Instead, they are often stabilized locally and then transferred, as I just mentioned. This staged approach exists for good reason. Many community hospitals, the smaller hospitals, are excellent at early resuscitation, airway, fluids, hemorrhage control, even if they lack subspecialty services. From a patient safety standpoint, early stabilization followed by controlled transfer is often safer than prolonged transport to a distant facility. All right, so here we're going to discuss EMTALA. So this defines three responsibilities of participating hospitals. Defines that hospitals that accept Medicare reimbursement. Okay. So the Emergency Medical Treatment and Active Labor Act. Um, this states that all hospitals are to provide all patients with a medical screening examination (MSC). In addition, they have to stabilize any patients with an emergency medical condition. In addition to that, they have to transfer or accept appropriate patients as needed. So EMTALA in practice, this governs how and when patients may be transferred, not whether they are convenient to transfer. Big difference there. Three things must happen. Always remember, medical screening exam, stabilization of emergency medical condition, and acceptance by the receiving facility. Inappropriate transfers, meaning no acceptance, no stabilization, or financial motivation, are EMTALA violations. These carry serious consequences such as fines and loss of Medicare funding. So, if the patient does not have insurance, EMTALA laws state that the facility has to see that patient and at least perform a medical screening examination. Okay, so I understand the slide is dense, but it's incredibly important, okay? So EMTALA defines an emergency medical condition broadly and intentionally. Any acute symptoms that could place a patient's health in serious jeopardy, impair bodily functions, or cause organ dysfunction all qualify. This includes severe pain, not just abnormal vitals or labs. From a PA perspective, this definition should make you cautious. If you are unsure whether a condition qualifies, it probably does. Okay, so we'll go over what's in bold here. So acute symptoms of sufficient severity. For example, heart attack presenting with intense chest pain and shortness of breath. Severe pain. Here's an example. Kidney stones causing excruciating back or abdominal pain. Absence of immediate medical attention could result in placing the health of the individual in serious jeopardy. For example, anaphylaxis. This can lead to difficulty breathing and potential death without prompt treatment. Serious impairment to bodily function. For example, a stroke can cause sudden weakness, numbness on one side of the body, impairing movement, impairing speech, impairing consciousness, impairing vision. So serious dysfunction of any bodily organ or part, for example, acute appendicitis. This can cause severe abdominal pain and risking rupture, leading to infection, sepsis, and organ failure, and ultimately death. With respect to a pregnant woman, health of the woman or her unborn child in serious jeopardy. Okay, for example, an ectopic pregnancy causing severe abdominal pain and internal bleeding can lead to patient demise quickly. This will endanger both the mother and the fetus. So these are just some examples of how EMTALA is stated and allows, well, doesn't allow it, mandates the hospitals to see patients. Okay, so up to now we've discussed EMS operations and legal responsibilities. The next section, we're going to shift into documentation and operational execution. This is where either systems succeed or fail. Okay. So EMTALA transfer form. So here is a little walkthrough through the anatomy of an EMTALA transfer form. Every element exists to protect the patient and the providers. Patient identifiers, accepting physician, reason for transfer, current vitals, risk of transport. These are not administrative details. They represent continuity of care and legal accountability. Incomplete or inaccurate forms are one of the most common contributors to EMTALA violations, and you do not want to be involved with that. So this case scenario is intentionally straightforward to reinforce the process, okay? I'm not here to trick you, it's just to help you internalize what appropriate transfer documentation looks like. As PAs, you will often be the clinicians completing or reviewing these EMTALA forms. Treat them as clinical documents, not just random paperwork, okay? So this continuation here enforces that EMTALA documentation is not optional. It is scrutinized after adverse events, complaints, or audits. So clear documentation protects patients, EMS, and the hospital staff. So here's just an example of the form here that I wrote for you guys here. If you want to take a look at it. And here it is filled out with the information from the case scenario. So this one here is completed. This is a completed EMTALA form. So notice how the clarity, completeness, and timing is well structured. These forms should tell a story: who the patient is, why they need the transfer, what has been done, and what risks remain. All right, so now we pivot from legal structure back into operational reality, right? So how EMS actually delivers care in the field using equipment and communication systems. Urban EMS systems rely on advanced communication infrastructure. Trunking systems, we'll go over in a second, allow many users to share limited frequencies efficiently, while cellular and personal communication systems provide flexibility. From a clinical standpoint, communication failures are far more dangerous than equipment failures. A missed radio report can mean missed antibiotics, delayed trauma activation, or unprepared airway management. So, trunking communication pathways. Let's explain this. So, a trunking system. So, in a trunking system, communication pathways are managed by a central processor. Okay, this allows a large number of users to share a relatively small number of communication frequencies efficiently. All right, so for example, imagine a busy airport where multiple airlines need to communicate with their ground staff. Instead of each airline having its own dedicated frequency, they share a pool of frequencies managed by a central system. When an airline needs to communicate, the system assigns an available frequency from the pool. Cellular and personal communication systems, also known as PCS. There is a PCS network, okay? These are end-to-end digital systems used for personal wireless mobile communication. They support voice and data applications such as email and file transfers. For example, think of your smartphone using a cellular network to make calls, send texts, and access the internet. PCS networks use specific frequency bands, for example, 1900 megahertz, to provide these services. So here's a comparison between the trunking and the PCS system. So this highlights why redundancy matters. Trunking systems are reliable for public safety, while PCS offers versatility. In disasters or mass casualty events, communication overload is a major threat. Understanding these systems helps explain why communication sometimes breaks down despite um, best intentions. I do remember when I was a grad student at Syracuse in Syracuse, New York, when 9/11 happened. Um, my cell phone wasn't working. No one could get a hold of me. I was only a few hours away from the city, but that's an example where trunking systems specifically for EMS and hospitals is going to be much more efficient because they only know about a specific frequency and share that frequency within the people that matter and need it the most. Whereas PCS, personal communication devices, they share even broader networks and they can become overloaded, and next thing you know, calls aren't getting through. That is the main difference between the two, you understand. Okay, next, universal precautions. They exist to protect all the providers, especially EMS, by extension, and the patient. So gloves, mask, and eye protection should always be routine, not optional. As future PAs, you are expected to align with safety culture. If the PP is not used consistently, you increase your risk for everybody involved. So use the gloves, use the gowns, use the eye protection. Okay, protect yourself. So when we discuss PPE and hazardous materials, in rare but high impact cases, EMS encounters hazardous materials, chemical spills, toxic gases, biological threats. In these situations, provider safety comes before patient care. EMS must use appropriate PPE and may delay patient contact until hazards are controlled. This can feel counterintuitive, but losing providers creates more victims. Okay, here are some examples of hazardous material or hazmat exposures. Number one, chemical spills. A tanker truck, for example, carrying hydrochloric acid overturns on a highway. This will release the acid onto the road and into the environment. This can cause severe burns and respiratory issues for anyone exposed. Number two, toxic gas leaks. For example, a leak in an industrial facility releases chlorine gas into the air. Inhalation of chlorine gas can lead to respiratory distress, coughing, and chest pain. Number three, radiation exposure. For example, workers at a nuclear power plant are exposed to high levels of radiation due to a malfunction in the reactor. Prolonged exposure can increase the risk of cancer and other health issues. Number four, biological hazards. For example, a laboratory technician accidentally spills a vial containing a highly infectious virus, let's say smallpox. This can lead to the spread of disease and requires immediate containment and medical intervention. Number five, flammable liquids. For example, a warehouse storing large quantities of gasoline catches fire. The fire can cause explosions and severe burns to anyone nearby. Number six, corrosive substances. For example, a worker in a manufacturing plant accidentally splashes sulfuric acid on their skin. This can cause severe chemical burns and tissue damage. Number seven, pesticide exposure. For example, agricultural workers are exposed to high levels of pesticides while spraying crops. This can lead to symptoms such as nausea, dizziness, and respiratory problems. Number eight, asbestos exposure. Construction workers or people flipping houses on old buildings or renovating old buildings are exposed to asbestos fibers. Inhalation of asbestos can cause lung diseases, including asbestosis and mesothelioma. So, we're going to discuss at the bottom there, it's the acronym MAST. It's called medical anti-shock trousers. Okay, these have been used to increase venous return to the heart until definitive care could be given. This, combined with compression of blood vessels, is believed to cause the movement of blood from the lower body to the right side of the heart, up to the lungs, and up to the brain. So this is going to help us reintroduce yourself to the fundamentals. Okay, airway, breathing, circulation. Defibrillators, airway adjuncts, vascular access, these are the tools that save lives in the first few minutes. Some equipment like mask trousers, they kind of fall out of favor as evidence continues to evolve over the years. This runs that EMS practices dynamic must remain evidence-based. So they were used a lot back in the day. I think now with so many smaller freestanding emergency rooms throughout the communities, it can get people quicker to get stabilized. But I do remember patients coming in with these on when I worked in trauma. There's okay, so NP is nasopharyngeal, OP is oral pharyngeal, ET tube is endotracheal tube. Okay, so they will use that terminology on your rotation. So next thing is airway management. This is one most critical pre-hospital intervention. So EMS airway adjuncts range from basic to advanced depending on the provider level and patient condition. Oropharyngeal and nasopharyngeal airways are simple tools that can be life-saving in an obtunded patient by preventing tongue obstruction. Okay, endotracheal tubes provide definitive airway control but require training, experience, and appropriate patient selection. As emergency PAs, you should always assess whether the airway was adequately protected in the field and anticipate complications such as aspiration or hypoxia. Remember, they were probably intubated under extreme conditions at the time, so always check for that. Don't forget to use that stethoscope that is hanging around your neck. Okay. All right. So spinal mobilization. This reflects a long-standing priority in trauma care. The goal here is to preserve neurologic function, and it's the most important goal. So in addition, we want to minimize movement of the cervical, thoracic, and lumbar spine until injury is ruled out. However, never mind. So sorry, got lost here. But anyways, in addition to immobilization of the spine, you always have to take into the fact that if there's other injuries, if there's polytrauma, if the patient's bleeding, if there's got respiratory compromise, or any other concerns that the patient may have. The first thing we want to do is immobilize the cervical spine. That's first and foremost with a C-collar. You'll have one person with both hands at the top of the patient's head, with both hands at the base of the skull, stabilizing the head and neck while the C-collar is put together. It usually comes in two pieces and placed together by the EMS team. So there's also backboards. Those are straight boards with multiple handles throughout. And once the patient's C-collar is stabilized, they do a log roll maneuver and put the backboard on the posterior part of the patient and slide him over. This is a team approach. When I was an athletic trainer, we worked with the paramedic teams to backboard several athletes that had head and neck injuries. So I got to experience that quite often. It's a very critical situation there. Okay, the point is not to allow any type of movement along any region of the spine. Here's what a spine board looks like here. They're usually orange for perfect visualization. When someone says go get the spine board, you know where it is. It's usually where all the other emergency equipment is located. This is a very utmost priority in trauma care, spine immobilization. So just keep that in mind. That is an example of a C-collar right there that's put together by Velcro, that yellow square there on the rectangle on the side. That's the Velcro that's put together. Another thing I want to talk about is the football helmets, okay? I don't want you to just take the football helmet off when a player goes down on the field from tackling somebody. You know, that thing stays on, okay? The combination of the football helmet and the shoulder pads will help hold the head in the optimal position for neutrality of the cervical spine. When I was an athletic trainer, we had battery-powered screwdrivers in our back pockets in case we had to remove the face mask. So the only thing you should remove from a football helmet in an injury like this, if you're ever covering a sporting event, and a player goes for a tackle and is laying motionless, face mask. I say this because you will have to get to the airway. If you take the helmet off, you're going to risk cervical spine injury and paralysis. But yeah, do not remove the football helmet. So in addition to this, any other type of athletic helmet, such as lacrosse or hockey, also leave those on to maintain spinal immobilization. The only ones, motorcycle helmets, they do not maintain a neutral spine position. So obviously, if they have the shield down, you can't get to their airway. So obviously, it'd be a two-person approach. One will stabilize head and neck, while the other one will carefully remove the motorcycle helmet. So know this very well. I don't want you to not ever understand the reasons for why I say this. So here's an example of a football helmet. You can see here that we've got the screws here, Phillips head. There's one here, two on this side, two on that side, and the mask comes right off, and you can insert an oral airway if needed. But yeah, here's a little plastic piece that's held in. But yeah, we just rip that right off with the screwdriver and get to the patient's airway. But keep the helmet on. The helmet and the shoulder pads are going to keep the head and neck neutral and prevent further spinal cord injury. So next we're going to discuss extremity immobilization. So there's several types of immobilization devices out on the field. With EMS or athletic trainers who are covering sporting events, so quite use these a lot. So air splints or circumferential bladders, they're kind of like those packing bubbles you get from Amazon inside your boxes, but a little bit much more higher quality. So these are deflated. You place them around the involved extremity, and there comes a little pump with them, and you pump them full of air, and they will help stabilize the fracture in the extremity. Traction splints, these are going to allow uh, immediate and prolonged traction on an extremity that's broken, or even the fracture. That will decrease pain and allow the patient to be more comfortable en route to the hospital. Femoral traction splint, so traction splints. So these are preferred devices for uh, mid-shaft proximal fractures because the legs can be shortened. I put a lot of these on in level 1 trauma center, but yeah, it requires you drilling, making an incision on distal third of lateral thigh through the IT band and drilling a hole into the distal femur and putting the pin through and applying it to the cables and traction devices with weights to allow for femoral traction of the extremity. Okay, these are different brands that they have there, but yeah. So in addition to that, tibial shaft fractures, you can do those with an air splint as well. They also have them like a knee immobilizer that's long and it also has a little bit of traction on there. But yeah, so tibial plateau fractures, I don't really recommend traction devices for those, or dislocated knees, because you've got compromise in nerve and vasculature in the posterior knee with those types of injuries. So here's an example of the air splints or circumferential bladders. So when you're out there on the field, they're easy to apply. You must monitor them closely. You may cause some more neurovascular compromise or undue swelling. So it's important to check capillary refill and pulses, specifically with extremity injuries. Here's some example of traction splints I was talking about earlier. So these are helpful for reducing pain, primarily in femoral shaft fractures. They'll restore length and alignment, make the patient feel better. You have to be trained in how to do these things, so you don't want to just apply this on without the proper training because you make the condition worse. So if you don't know, ask. But here are the different types here that they have, okay? All right, so here's a list of medications that are commonly carried by ALS units. These drugs address life-threatening conditions such as hypoglycemia, chest pain, bronchospasms, seizures, arrhythmias, anaphylaxis, and opioid overdose. As PAs, when you receive a patient, you should confirm what medications were administered pre-hospital and when, as this affects ongoing management. Okay, so when you're doing your FRTG simulation and the paramedics delivering you the actor patient, you need to ask if they gave them any medications and also what's going on, what happened, anything I need to know about. So just understand that they will already be delivered to you with some sort of medication administered to them already. Um, Here's something I want you to pay attention on. So air medical transport. This includes both helicopter and fixed wing aircraft, like a Cessna jet. These services extend critical care capabilities beyond ground transport, especially for interfacility transfers in remote locations. However, um, air transfer is not simply faster ambulance care. It's a distinct clinical environment with unique risks and limitations. All right, so this is something that is carefully thought out. I'll give you a real world example. When I was an athletic trainer, like many moons ago, uh, it was a time where this was at UCF. Time where UCF was in the middle of building their new sports mecca that they have there now. So we just had some football practice fields, and they had just um, taken down a large part of the forest to build a new stadium. So there's a lot of bumpy dirt roads and stuff going on back there. So yeah, we had a player collide with another player, and he fell face down and was motionless. And we did the head and neck stabilization. We took off his face mask. We gave him oral airways before the paramedics got there. The paramedics had to park down the street, and we brought them over in our little cart. And in that situation where it took, there was a lot of construction everywhere, the roads were not really safe or ideal or conducive to a spine injury patient. They had to call the air medical transport, so the helicopter landed in the middle of the practice field and they took him away. Um, Luckily, it was just a brainstem contusion, and he was able to play again. He actually went to the NFL. But yeah, so that's just an example there of how air medical transport is coordinated, um, where it would have probably been much more of a risk to transport the patient on a cart over a bumpy dirt road to the ambulance. So it would have delayed treatment, and in that type of situation, you can't take any chances. So that's just an example there. All right, so it's abbreviated HEMS for helicopter EMS. So there's usually a team, they call them flight nurses, flight paramedics, flight surgeons. These have advanced training. So they are ICU level care that are responsible during the transport phase of medical care. So I want you to understand what HEMS can and cannot do because it helps set realistic expectations for incoming patients. So if you have an idea whether they came in through an ambulance or a helicopter, you kind of have to go through your head, okay, so they were capable of doing this and that and this. So you have an idea of what type of care they received prior to them being handed off to you. So there is a modest survival benefit for certain trauma patients that are transported by helicopter, as evidence suggests. However, this benefit is not universal. HEMS use must be justified by patient acuity, distance, and time sensitivity. Overuse of HEMS risks and costs without improving outcomes. Okay, so time and distance factors. If you know that there's a big traffic jam on I-4. Every exit has a traffic jam. It's going to take longer for ground support to effectively treat that patient. Then air medical transport can be an option. Okay, so as you can see there at the bottom there are some statistics there. So transportation to hospital by helicopter for trauma patients, there's a 1.5% increased rate of survival. So for every 65 patients taken by helicopter, a life will be saved. So it does has its benefits, okay? All right. There are some precautions with transport. So the actual transport is a physiologic stressor, just like we discussed that surgery is a stressor for patients. So before transport, EMS will stabilize the patient as much as possible and anticipate deterioration. So they're going to have to continuously monitor vital signs, oxygenation, ventilation, which is quite essential, as you might believe. So particularly in the critically ill patients or highly traumatic injured patients. So just like in the hospital, when you transport a critically ill patient from their ICU to imaging room, there's always risks of transport. In this situation, it's a risk of intrafacility transport. So moving critically ill patients adds layers of risk. For example, noise, vibration from the vehicle or the helicopter, limited space in the vehicle, and reduce access to personnel and equipment. They only have what they can carry. Remember that. So these factors can exacerbate underlying illness or injury. And this is why careful preparation and experienced transport teams are so important. And you need to basically know what you're doing. Okay. So these are all factors that can affect the patient here on this slide as far as interfacility transfers is concerned. So As far as pediatric transport, so many community EMS systems are not equipped to transfer critically ill children. Pediatric interfacility transport often requires specialized teams trained in pediatric physiology and equipment. This will help to reduce complications and improve outcomes. Okay, remember they're smaller. And an adult airway won't work on a pediatric patient like this baby here. So they have to have the specialized equipment for a pediatric patient and an infant, and also the capabilities and training to specifically help those types of populations. So hypothermia, we'll go over this in another lecture, but hypothermia is one of those dangerous threats to neonates during transport. Newborns lose heat rapidly and have limited ability to regulate temperature. So your main priority is to prevent hypothermia, which will help prevent further demise. So drying, warming surfaces and appropriate environmental control are highly essential for the pediatric patient. So neonatal hypoxemia, this is a common finding, respiratory compromise in neonates. They don't have the most experienced lungs. They basically have immature lungs, okay? Their surfactant could be deficient. They could have a congenital heart disease. So during transport, ventilation adequacy must be continuously assessed through chest rise, skin color, and oxygen saturation. So look for signs of respiratory demise as well. Neonatal hypoglycemia. This is the most common metabolic abnormality in newborns, okay? Because neonates have limited glycogen stores. Um, so in addition to that, fluids, the ones that contain glucose, are essential to be administered to the patient during transport. So any failure to address hypoglycemia in this population can result in permanent neurologic injury. Vascular access in the neonatal population. This is challenging. Umbilical venous access is often used in infants less than 1 week old, but this requires specialized training and strict sterile technique. Infection risk. Infection must always be considered in sick neonates. Sepsis can present subtly and progress rapidly. Remember, they cannot really communicate this. So empiric broad-spectrum antibiotics should be administered early when infection is suspected, particularly in premature infants who are in an emergency situation. This final neonatal slide here addresses viability and ethical decision making. Advances in neonatal care have improved outcomes for infants born at or beyond 24 weeks gestation. So these transport decisions must consider prognosis, available resources, and family wishes, emphasizing compassionate, evidence-based care. All right. Another thing, children will always experience significant anxiety during medical emergencies. So allowing their parents or caregivers, their guardians to remain present can reduce the stress and improve cooperation. It's a simple but powerful intervention. This will help improve both the patient experience and physiologic stability. In regards to pediatric respiratory fatigue, infants and children can maintain normal appearance until they suddenly decompensate. Respiratory fatigue often precedes rapid deterioration, so early recognition and intervention are critical, especially during transport when resources are extremely limited. This concludes our discussion of pre-hospital care. The key takeaway here is that EMS is not separate from emergency medicine. It is its foundation. As future PAs, your ability to understand EMS systems, respect pre-hospital decision making, and integrate field care into hospital management will directly impact patient outcomes. Thank you for your attention, and goodbye.